Hello, and thank you for being here. This is Making Sense of It. And our speaker today is senior faculty Nancy Herrick, and her topic is on choice theory, adding understanding for caregivers. And we've been chatting back and forth. It's how the older that we get, the more difficult it is to remember, let alone taking care of those even older than we are. And so Nancy's going to be asking the audience today to do some sharing, especially those that have caretaking tasks within their purview. So welcome, everyone. Welcome, Nancy. It's good to see you.
Thank you very much.
You are.
This has been a real effort to get this together because I've been working on this for a long time and never had anything really succinct, that I can really talk about. But I'm going to do my best. And like I was telling Mona, I don't have good knowledge on this. This is just my opinion with very minimal amount of understanding. So I'm hoping that you guys can fill in and help out and explore and expand this information and this knowledge so that it can eventually be useful to anybody that has CTRT certification. Because I think we're going to need this information and this knowledge in the next millennium for sure. So anyway, so I'm going to share my screen. Let me see here. And then I've got to figure out how to get it to. Okay. So do you have full screen now, everybody?
Yes.
Okay. All right. So I called this effective skills for care partners. I've been doing a lot of reading from and watching the internet and so forth. Tifa Snow's materials on positive approach to care and her organization. And she's a marvelous instructor to help us to learn the skills and the knowledge. But this is, I'm going to try to add the choice theory part of it, which she doesn't know, but she does include a lot of our concepts. She just doesn't have them in our vernacular, the words that we use. But this is my idea of how choice theory can add a dimension of skills for caregivers, she calls them care partners, for memory care workers, if they're in an organization or an agency, a memory care home, whatever. And to create the conditions for the dementia patients to find enjoyment in their world, regardless of the level of their neurodegeneration. So that's what we're looking at today, is how can we add things to what's already being taught and being used out there that'll make even our people who know choice theory even stronger to help people out. So what can we offer that others don't have to offer? Well, we have the knowledge and belief that all we do from birth to death is behave. So until these people are gone, they're still behaving, just their brain is diminished. I mean, they say a lot of times they lose 2/3 of the brain before they die in a lot of the dementias. Maybe not in every one, but in a lot of them. But they're still behaving, and the brain is still trying to work just like we say that it does. All behavior is purposeful. It's to satisfy our basic needs, and this is the piece about for the dementia patients. Your behavior is your best attempt at that moment of time with what you have available to you, the information from the outside world that you have, your perception of it, your understanding of it, and what's left in your brain that can make sense of it. So it's your best attempt to satisfy your needs at the current moment of time. And what we know is they're losing so much of their perception, so much of their ability to utilize the information when it gets into their brain, so forth. Our needs don't change, but the satisfying pictures do change. And that's what we have to be looking for. And all our behavior is our control of perception. Well, we know with for instance, two of the different kinds of dementia, their perception is very skewed. So they don't even get in the information that most people would get in, or that a normal or a healthy person would get in. So it doesn't even come into the brain, let alone being able to process it. So that's why we have to recognize that their behavior is only according to what they can perceive. And we have to remember this: all we can do is control our own behavior. We all know that, but it's very hard to do when you're trying to work with someone who doesn't understand and can't make sense of things for themselves. So hope we can make sense of this a little bit today. So dementia, this comes from Teepa Snow's work website, Positive Approach to Care. She says it's like a big umbrella. We used to think it was just brain injury or Alzheimer's, but Alzheimer's is only really a small part. It's not nearly the whole thing. And now we used to say, you can see that it's a big raindrop under Alzheimer's disease, because we used to think that a lot of dementia was Alzheimer's. And Alzheimer's does play a part in some of the other sorts of dementias also. So you may have one that's more predominant, but there may be Alzheimer's or memory loss along with it. So it depends on what parts of the brain are dying or what parts are degenerating, and where that's occurring, to what kind of dementia that might be. There's a frontal temporal dementia, which is where you lose, this is the last part of the brain that develop, and so it's usually the first part that gets diminished. And this is where you lose logic and reason, where you lose not necessarily memory, but you lose logic and reason, you lose impulse control, you lose some of your language and so forth. The vascular dementia, which is usually what we used to think of as strokes or heart attacks, can cause the vascular dementia, but there's other kinds too. There can be a genetic reason for vascular dementia, which is the closing off or the dying of the blood vessels, so that they're not getting blood to the brain, and then the brain cells die. So CADASIL is the genetic thing that's going to cause vascular dementia, and you don't know until you start. You don't know if if it's genetic or not until it's pretty evident. Then there's Lewy body, which is becoming more and more understood and recognized more often. And now it's probably just as big a bubble as, or a raindrop here, as Alzheimer's, even though when she created this graphic, it was probably several years ago. But now they're saying they see a lot more of the Lewy body. They're recognizing that it's even a stronger loss than the Alzheimer's. So, and with Lewy body, you may also see some Parkinson types of motor problems. You're also going to see a lot of confusion, disorientation, and things like that. And some of that comes with Alzheimer's, but some of it doesn't come until late stage Alzheimer's, where in Lewy body, it might come first. It might be there early. Then there's also, and I can see if I can move this thingy over here. There's also like lots and lots and lots of other forms of dementia. And we're not going to go through all of these. I'm not going to explain them all because I don't even know about all of them. I'm trying to study them, but I really don't have a lot of knowledge on them. So let me go to the next slide. You can see, anyway, let me just say before I go to the next slide, they used to think there was 4 or 5 different kinds of dementia. Now they think there's 120 different forms of dementia. So, I mean, this doesn't even, we're not even touching the whole thing yet here. Okay, so let's look at some of the differences between some of them. And notice the thing at the top of the page. What dementia means is that at least it's a syndrome of things that are happening. It's not a diagnosis that you can make specifically. We have to look at all the symptomology and say, well, this looks like, or this appears to be, because until we can actually do a postmortem of the brain, we don't really know how much or what is lost. We can, with the MRIs and so forth, we can see a lot of dead cells. We can see a lot of problems with the brain, but we may not be able to tell exactly what's happening and where and how fast and so forth. So at least two parts of the brain are either dying or losing oxygen, so they cannot function. It's incurable, can't fix it. It's chronic. It keeps changing and getting worse. It's progressive. And the last one is it's going to result in death, because eventually you're going to lose enough of the brain to not be able to control heart rate, respiration, and so forth, and you will die. Most people die not because of that, because it doesn't get that far. Most people die because they get infections that they don't recognize, that their body is not aware of, and they can't tell you about them, and therefore the infections get so bad they kill them. For instance, pneumonia is probably one of the highest reasons for death in dementia patients, and people don't even know they've got pneumonia. And the other one is a UTI, lower abdominal problems. People don't even know it. They know there's something isn't right, but they can't tell you what it is, and it's very hard to find until you get them to the doctor and get them checked out. And then sometimes you can cure those infections and it doesn't kill them. But if you can't get to it in time, those infections are the ones that usually kill people rather than the dementia itself. So Alzheimer's. Details are the newer things. The most recent memory is lost first. So things that were created last are the first things to go. So even in almost all of them. So you lose some language, you lose you have some impulsivity, you become indecisive, you get lost in time and place, depending on how fast or when you have Alzheimer's setting in. There are two different kinds that they classify, and that's the young onset or early onset, and then late onset. And that's early onset is before 50 or 55. Late onset would be after that. Down syndrome is also another. These people are very much high at risk for Alzheimer's eventually. We know that Alzheimer's comes from the beta amyloid plaques and tangles in the brain. It's how the neurons tangle themselves up and cannot keep their own shape and function. And so you lose control. Lewy body is another one, like I said, is getting more and more understandable. You can see it has a lot of the same things: visual disturbances, delusional thinking. You'll see more fine motor problems. They lose the fine motor skills first, and they begin to have more rigidity of their muscles and their control. They usually have a lot of sleep disturbances, nightmares, hallucinations. All these kinds of things are coming because their perceptual system and their visual knowledge is being threatened, because Lewy bodies is actually affects more of the frontal lobe. So vascular dementia, that's usually this is the one where it's the low blood flow and till the cells die in the brain. Sometimes the vascular dementia is odd, because you'll see some disability like memory loss or confusion or frustrations with can't find the words or can't find a place or can't remember things. But then the next day, maybe they're clear as a bell again. So it fluctuates. Sometimes they'll have a blockage of veins or arteries in the brain, and it will turn off so that they're not getting oxygen to certain parts of the brain. But then the next day that'll unplug itself and they got it back again. So it goes back and forth, but it is progressive. It's going to continue getting worse. It's not going to go away. So anyway, it says least predictable, because people don't know what's happening. Why can't I remember that today? And then tomorrow it's clear as a bell. So it's very unpredictable, even for the patient or for anybody trying to decide what it is. The frontal temporal, and there's many kinds of this, but most of this is where you start losing interest in things. A lot of times depression looks like this to begin with. And then you'll start to see a lot of other things, like you'll lose your speech, you'll lose language, you'll lose words, you'll lose place and time. All these different kinds of things go. So these are different kinds, and that's why it's when you start to see something in someone, yes, there is normal aging, and we do lose certain capacities as we get elderly anyway, because the brain is changing all the time. However, if things don't look normal, if it looks like very different than that person was before, it's a good idea to get it tested and looked at and decided, because you can start to make plans and you can start to deal with it in better ways, instead of just saying, well, you should remember that. We just talked about that yesterday. Don't ask me that question again, because we just asked that 4 times yesterday and I had told you 4 times. So it's when you can do that, instead of arguing with people and making them feel bad or feel stupid or feel like they should remember, and then they start to guilt or feel bad about themselves. If you know that this is happening, you can take advantage of that and say, that's just where I am right now. Thank you very much. Let's move on. Okay, I don't remember that. Tell me again and we can move on. And I may not remember tomorrow, but I may ask again, but please, just respect that I don't have that memory anymore. So anyway, this is the brain and kind of what it looks like. So the center of the brain, this is, you'll see a lot of symptomology, because this is the part of the brain, this is the amygdala, where you have the emotions, impulse control and emotions. And this also, and the brainstem, these are the first parts of the brain to develop and the last parts that we lose. So even though we might lose the occipital lobe, which is the vision and perception of things, or the frontal lobes, which is understanding and being able to utilize the information and make it make sense, or any of the other things like hearing and those kinds of things, memory and speech are all in here. Those will go before their emotional system goes. And so they have strong, very sensitive and very strong emotions. And that's what you'll see: a lot of anger, a lot of frustration, a lot of hostility, because you're just not getting it. You're not telling you, I'm not, why can't you understand me? And so that's because that's part of that amygdala. It's part of that limbic system. It's part of that emotional system that doesn't go away. They know they aren't making sense. They recognize this, and yet they can't do anything about it. And it's very frustrating. So vision is in that occipital lobe. That's that little purple part. What we figured out is, especially with Lewy body, when your perceptual system is diminished because your visual acuity is diminished, you don't even take in all the things other people would take in and pay attention to. So it's like, to begin with, it's like you've got on a mask of like a scuba mask, and you can't see outside that scuba mask. You can see up and down, but as far as, but your peripheral vision is gone. Then pretty soon it gets worse, and now you're down to like binoculars. Now you can only just see a very small amount of the information, and you are going to be more focused on things or people's eyes or what's happening, but you can't see both at the same time. Okay, so because your perceptual system is not picking up on all that peripheral vision. So when that happens, you don't have as much information to process. You can't determine what's going on and how to deal with it. So at the same time, you may be losing other things too, like memory or some of the other things that are going on. Auditory data, we know this happens a lot. Speech production is all right in here in that temporal lobe. You don't lose the production before you lose the words and the vocabulary. Just think about a new baby. they can ba 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 la la la. They can do that before make speech before they can come out with a word. So the words are going to go before the speech does, before the auditory goes. But eventually that could go too. So in the later stages of a lot of these, that goes also. Anyway, so you can kind of see where this is. The prefrontal, this is when that cerebrum that gets developed last, logic, reason, making choices, self-awareness, awareness of other people and what's going on around them, all of that. When that starts to die, they're going back to being more infantile, being more don't understand, no caution, no awareness of safety issues. They take greater risks because they don't sense that there's anything that could hurt them. It's like like a little toddler sticks his hand or his fingers on the hot stove or into an electrical socket. He doesn't know that's dangerous. And this is a problem when the prefrontal lobe is attacked. So we have to be very careful because they don't have that awareness of caution or safety or, being able, knowing about what's happening in their body. Even they might not understand what their indigestion is because there's something wrong, but they don't know what it is because they can't tell that it's indigestion, that it's just in their stomach or just in their intestinal tract or whatever. Okay, so because they don't have that awareness of their self. Okay, so the other thing that you'll see them lose quickly is being able to continue a sequence of things and finish it and move on. So this is where people get stuck, and you'll hear them saying, well, what do I do first? And then you'll say, well, this is what you're going to do first. Yeah, show me where, show me how. And then they can't pick it up and do it. And if they do it, they say, now what? Or they get stuck in a cycle of doing it over and over and over because they don't know how to break that cycle and move forward. So some of those are the conditions that you see. Okay, let's keep going. So this is kind of this is my image, which is not very good, but excuse me. This is my choice theory chart of what would happen in your brain. So much of the information coming in through, I don't know if you can see my cursor. Can you see my cursor?
Yes, we can see it.
Okay. So much of that is diminished because hearing loss, because of vision loss, so forth. You don't even get a lot of information all the way into your knowledge filter. It doesn't even get in there. So if it doesn't get in there, you can't process it. So, but what does go in there, now that's knowledge. And we're going to take it in and decide whether or not it matches our quality world. And we still have quality world pictures. We still have all our basic needs. So we got to decide what it matches, where it comes. Oops, excuse me, go back. Decide what it matches. And we're going to put that up here. And then, but because we don't have enough understanding of everything around that, we don't know. Usually it's just a small amount that is getting through to that smaller brain, because the brain is getting smaller and degenerating. And there's a lot of red because other people are trying to tell me what to do and what's not. No, that's not it. That's not right. And so I'm much more going to be unbalanced in situation A. And when I'm unbalanced in situation A, the signal to behave is still very strong. But I don't have as much repertoire to behave with. So my wheels are still, I couldn't put wheels on this. The wheels are still there, but I don't know how to control them. So I do a lot of really funny things because I don't know what to do with them. So my organized behaviors may still be there. I may still pat things or touch things or pick things up because that's an organized behavior, but I don't know what to do with it when I get it picked up. I don't recognize it. What is this? I don't know. Or I recognize that it's something I like. It feels good to me or whatever, and I'm not going to let go of it because I don't have anything else. So when your perceptual system is shutting down. Your total knowledge filter is closing in. Your quality world is just as big as it ever was. Pictures have changed, but it's still just as big as it ever was. But your total knowledge filter is changing, or your all you know world is changing, because the brain is changing. And so we're going to be more often in situation A with higher emotional stress, because we know we don't have it, but we can't figure out how to get it. How do I put 2 and 2 together to make it work? So you can see why it's very, very difficult for people going through dementia. When they first recognize it, they don't want to admit it because maybe it's just normal aging. But now I'm noticing it, and then pretty soon I'm not even aware of it anymore, but other people are. Okay, so whose behavior can we control? We can only control our own behavior. So if we recognize that, are we going to try to make them external control them to do something that they don't want to do? And that's going to be very hard or difficult. And that's what I think happens to many of the caregivers. They think they can tell them, well, remember that? Well, you did that yesterday. You can do it again today, but maybe they can't. So let me see if I can move this. So the top 10 mistakes that most people make is, I believe I can get him or her to understand or to remember. So if we think we can control them to understand or remember, but the brain is not there for them, we're barking up the wrong tree. Okay. We argue, we correct them, we say, remember, we talked about that. We think they should be able to do this, or the person thinks they can do it, but they don't have the skills to do it anymore. Or they get started, but they can't finish. They don't know where to go next. Okay. And that we think many times that they're being defiant or mean or nasty, or that they don't want to do something. And that may not be true at all. They may not understand what we're even trying to get across to them. So we get frustrated, they get frustrated. We're very frustrated when they ask the same questions over and over, because that's often what comes first, is I forget that I asked that question, or I forget what the answer was, so I ask it again. So like a little kid would do over and over, you say, don't ask anymore, right? But you see, if they don't have the information and they can't hold it in their brain because those brain cells are gone, they're going to be repeating and repeating. So many times we start to demand, or we fight with them, or we yell at them because we think they aren't hearing us, or we nag or whatever. And especially when it comes to health issues like eat your food, or you have to eat this, or you're not eating enough, or you're not eating the right foods, or toileting, or showering and cleaning your body and keeping it clean and so forth. These are the things that caregivers just want. They believe you need to be healthy, and yet the person who is the dementia person doesn't necessarily have that knowledge or that understanding or that awareness. We sometimes perceive them to be a problem. What am I going to do now? This is a problem. And we begin to take, what happens here is we begin to break the relationships. When I start to perceive them as a problem, I'm going to break the relationships with disconnecting habits, because I'm not going to like it. I'm not going to accept it. I'm not going to listen. I'm not going to, all those different things. Because this is not the person they used to be. And I want the person back that used to be here. Well, they're not coming back. So then the other thing we do is we begin to rob them of their independence. Oh, you can't do that anymore. Well, you shouldn't drive the car anymore. Maybe they shouldn't. But when you rob them of that independence without getting them to understand or to make sense of it for themselves, they're feeling like they're being trapped, and they're being forced, and they're being crucified, and they're being judged, and so forth. So we have to be very careful to allow them to do things that they still can do, to make decisions they still can make, to have fun, to enjoy something about life that they used to enjoy, that they can still enjoy. And like, for instance, music and rhythm, that usually goes last. So that usually lasts way into the late stages of any of these dementias. So rocking, you'll see people rocking because they like the motion, and it helps to keep their brain moving and thinking a little bit. But you can do things with them like dancing, and they'll remember. If you say something like Mary had a little, they can come up with lamb because it was something they learned very early on, and so it isn't gone. But if you ask them to do the nursery rhymes, they don't remember nursery rhymes. If you say Mary had a little, they got it. The cow jumped over the moon. Okay, they'll have that. So you see, it's things that they learned early on. Many times those words are still there, even though they've lost a lot of their language skills. Okay, come on. Okay. We often get embarrassed when the person says something that's inappropriate, mean, nasty, crude, because they lose their inability to understand others and how other people may be sensitive to certain things. They also keep those swear words because those have a lot more emotion connected to them, and they haven't lost the emotions. So the swear words come. So they'll give you all kinds of swear words, or you're an imbecile, you're stupid, you're an idiot. Those words have emotion connected to them, so those will still be there. But they're trying to say you're a beautiful girl, but they can't say that. They say you're fat, or you're ugly, or you're something like that, because they can't come up with the words they want. And then we sometimes resent that other family members will not help out with a person as their dementia is getting worse, because they don't understand them, they're not around them as much, or they just can't take the fact that this person is changing. And the last one is that we allow that caregiving that we're trying to do to allow stress in my own life and rob me of the life I should be living. So this is one of the things we don't want to do. So we have caregivers and care partners need to understand that when things are getting worse and worse, you need to take care of yourself by getting the help you need, whatever that is, whether it's other family members, whether it's other people in the community, whether it's a caregiving center or whatever, where people can go, because you're going to be too stressed out to be following and watching them every single moment and helping with every single thing. Okay, so choice theory, we can remember we have the connecting habits. The one thing we need to do is to connect. How can we connect with someone who's losing their connections? We have to understand them. So my belief is that we move back to really understanding, listening, accepting, respecting that this is still a person in there. They still are a caring, loving person in there, even though they don't have the capacity to show it. Okay, and then being supportive of where they are, encouraging of what they have, and then sometimes negotiating if you can get them to negotiate in any way, shape, or form. But we know these habits, we can use these. The other thing that I think we can use, which I've learned along quite a while ago, but I think this is very helpful, is if we learn the love language of the dementia person, if we can understand what it was like for them when they were healthy and in good shape before the dementia set in, what did they like? What was their love language? What did they like to hear? What did they give? And if we can remember that, we can go back to using their love language, because that way they will still recognize. That will be more recognizable to them than something else that we might do. So I think most of you know these things, but words of affirmation, if this is what they liked to do, if they like to use affirmation words, then use lots of those with them. If it was service, help them to do things. Help them, don't do it for them, but help them to do it for themselves or for you. If it was quality time, sometimes it's just sitting and reminiscing about the old stories that they used to tell all the time, that maybe they told over and over. If you start to tell the story, they will sometimes connect with it, and it's good quality time. Giving gifts, if that's what it used to be, probably is not going to be nearly as effective with dementia patients, because they won't understand what the gift is anymore. However, if that's what they enjoy doing, then little gifts such as finding their favorite socks and putting them in front of them that day instead of just any socks. So that might be the gift they get. So it could be little things. And physical touch. We know that some types of dementia, they don't want to be touched. They're afraid of touch. But if you are connected to them emotionally, relationship wise, usually some sorts of easy, gentle touch are affirming and helpful. So let me talk about a little bit about what I've learned from Teepa Snow. Well, this is choice that reminds us of all these things. Okay, let me see. We'll go back to this. I thought this was going to come down a little bit further. That I can only control my own behavior. I can't control them. That if I use gestures or show them something, it might help them to understand. But if I want them to do something, if I do it myself and then I help them to do it myself and then help them, then they get the idea we're supposed to eat. Okay, now you eat. But if I just say eat that, it's like they're not interested. They're not hungry. They don't care about it. They can't recognize it. So why would I put it in my mouth? No, get away from me. Okay. So using their love language, evaluating my own behavior, my tone, my intensity, how quickly I'm trying to get to them or do things for them. Slow down because they need more time to process. Talk less, fewer words, more gestures, more hand language, so that they can understand better. Remember that their real world is not the same as ours, and their world is getting smaller, not as big as ours, and they are not taking in as much into their perceptual system anymore. So you have to work with what they have left. If they only have binocular vision, then you have to get things right up in front of their face so they can see it before you come at them with it. You can't come at them from above because they can't see what's happening, and all of a sudden something's hitting me. Okay, so you have to work with what's left. We can't worry about what's gone. We have to work with what's left. So observe their behavior, the dementia client. Observe their behavior. What are they doing? How are they exchanging words? What emotional charge do they have? Are they very upset, just a little upset? Are they just questioning? And use your caring habits so that you don't escalate their emotions because you're not believing them, you're not understanding them. So some of the things that Teepa suggests, Teepa Snow's work on this, the positive approach to care. She says several things. She says, first you have, if their visual acuity is getting smaller, like we talked about, approach slowly, announce yourself, stop 6 feet away, call their name, say, I'm who I am. Hey mom, or I'm your daughter, or I'm your caregiver. I was here yesterday. And get down to their eye level, wherever their eye level is. If they're laying down, get down on get down on your knees where you're down close to their eye level so they can see you before you come any closer, and then come in slowly. Okay, so connect with their name, with your name. And if they're ready for you to connect by coming in closer and closer, connect with a hand out so they can see that you're just offering, but don't reach, but just gestures, slow, small gestures. Reflect their words back, repeat their words. If they say, I want to go home, say, you want to go home. Okay, I understand you want to go home. So repeat their words, and maybe they wouldn't get that. Okay, I understand. Maybe you need to leave that out. Maybe they're at the point where they don't have very many words. You just need to say, you want to go home. Yes, you want to go home. So you're affirming what they want. Doesn't mean you're going to give it to them. We're just saying this is how you connect with them, is to affirm, assure, agree with them, and empathize with them as much as you possibly can with where they are. You can offer if they're able to take something. If they're not hyper emotional, then you can probably offer something. Touch is one of the things that many people like when they know that you're coming towards them and to help them. They understand that. And Tifa shows you a hand over hand. I don't know if I can show it to you or not but you put one hand and put your thumb in their palm, and then they grab your hand and you grab theirs. So it's hand over hand, and your hand is underneath theirs. So everything you do, you're using their hand to help them. So it's like, if I'm going to pick up food, I pick up the food and I put it in my mouth with their hand. Then I pick up the food and ask them to, with their hand, and see if they want to put it in their mouth, that kind of thing. So you're helping to manipulate them in an agreeable way so that they understand that you're helping. Okay, use as few verbal clues as you have to, more hand signals and motions. You can interject new information when it is appropriate or you think it's necessary, but keep it simple, because they are not going to understand lots and lots of language, lots and lots of talk. The more you talk, the more frustrated they'll get, because they've lost the concept of where you're going. They don't understand. And now you don't understand me. So you can shift their attention when they're ready to shift. When you've got their attention and they're with you and you're connected, then you can begin to shift their attention, and hopefully to something they can assist you with, rather than you wanting them to do something. So I need your help with this. Could you help me with this? And if you can connect it to something that they're fixated on, for instance, if they've got something in their hand that they like, and they're just petting it and petting it and petting it, you can say, I have this soft blanket and it's so soft. Would you like to pet it? Would you like to stroke it like this? And then maybe you'll take their hand, and maybe then you can give them the blanket instead of something that might have been maybe dangerous or not so good for them to be holding on to. But before you add something new or interject something new, be sure that you're connected. If you're not connected in relationship, you won't be able to get anywhere. Okay, so we're going to look at this. This is maybe, no, maybe not. Let's see, it didn't come up. Here we go. I'm going to show you something with Tifa. I hope I got it in the right spot. I'm going to try this. She's going to show you situation B first, how to do this with someone who's doesn't have much visual perception. And then she's going to show you what might happen if you just go like most people would, not understanding. So situation A comes second. Instead of situation A first and then going to B, which is better, she's going to show you it the other way. So hopefully this will work. Now, do I have to share? I'm sharing my screen. Do I have to share my audio?
No, it should go.
It should go? Okay.
Uh-huh.
All right, let's see if it does.
So rather than just put her hand up and do this, instead I kept my hand behind hers and went like this. So I'm supporting the hand so when we hit it. So let's go ahead, and if she's blind, let's just do the approach if she were blind.
So this is what I want you to see.
So she can't see. So the knock knock though will work. I go knock knock. Amanda. Hey. It's Tifa. I wanted to come in and I wanted to say, hello, hello. Now, what you saw me doing there is I knocked at approximately the 6 feet range. And I said, knock, knock. Hey, Amanda, it's Tifa. So what I'm looking for in her, because she's not verbal in this case, and she's not got vision, I'm looking at a head positioning. And when I went knock, knock, I saw an alerting. And then I went, it's Tifa. And she's sort of trying to find me, which she has some localizing issues. I then kept my voice moving so that she could figure out I had gotten down. My near arm goes, and hand, open hand goes over the tendon right above the kneecap. Flat open hand, no fingertips. I lay my other hand, palm up, let her take my hand, and now I can transition into a parallel position. Hey. And now I can introduce whatever it is we're going to be working with. Ah, did she get it?
Mhm.
Yeah, really different. Keep your eyes closed. There you go. Then. Oh. No. It's Amanda, calm down. Okay, so what was the first thing? And this idea of, oh,
It's not letting me change. Wait a minute. I got to get off here. Okay. So you saw the visual approach, slow, stop, eye level, connect, reflect. She didn't have words, but reflect. It's me, I'm coming in. Okay. And then she got the hand over hand, and then she used her hand to show her what she was trying to ask her to do. So less words, more motions, more helping them by utilizing their hand to do things. Okay. So I just want to end up with, that's about all I can give you today, for instance, but if you are interested in the book that I used for the love languages, this is a, I've got this here in the last slide. This is a Gary Chapman book of the 5 love languages, and this one is for dementia. So it's called Memories, How to Keep the Love Alive When Memories Fade. And I have a whole case of them. If you want them, I will sell them to you easily, very cheap. Anyway, so I wanted to go to, if I can find this now, let me see. How do I do this? This was the song that Bill Abbott. How do I get out of here? Okay, I'm not sure how to get out here. That's my last slide. Wait a minute, see if I can go back. Okay, let me go back here. Okay, let me try to play this for you.
show me by your action.
It didn't start at the beginning, so. So anyway, it didn't start at the beginning, so I don't know if it's gonna get it here. Okay.
Okay, well, we were able to read the verbiage of it, so that was
Yeah.
Yeah, well, thank you very much. This has been quite enlightening, and certainly wants to be, needs to be passed on to others. So thank you for all of that.
So
And
I'm glad to share the PowerPoint with anybody. So they've got these graphics if they want them. Don't worry about the little graphic that I created.
that was very clever. I liked that.
But I wish I had a better graphic of it. Maybe I'll eventually draw something so it's more dimensional and so forth. But
well, we're going to close out the recording, and then we'll chit chat with those that are present. So thank you, Nancy, very much, and blessings to all.